Today we are going to discuss about the topic Addison's disease, also known as adrenal insufficiency. First we'll study about the hypothalamo-pituitary adrenal axis physiology, and then we'll study about the pathology part. First, from hypothalamus, there is a release of corticotropin releasing hormone, which will stimulate pituitary. Pituitary gland in turn will release ACTH, specifically from anterior pituitary gland, and ACTH will stimulate adrenal cortex. Adrenal cortex total releases three hormones. First, aldosterone, cortisone, and dihydroepiandrosterone sulfate. Out of these three hormones, only these two, cortisone and dihydroepiandrosterone sulfate, are controlled by ACTH. Aldosterone is controlled by renin-angiotensinogen system. So, ACTH only stimulates the release of cortisone and dihydroepiandrosterone sulfate. This will be the basic physiology of hypothalamo-pituitary adrenal axis. Now we'll study about the pathogenesis of Addison's disease. First, we'll study about the classification. In classification, Addison's disease is classified into primary, secondary, and tertiary. Primary, secondary, and tertiary. Primary means there is a defect in adrenal cortex itself. And in secondary, the defect is in pituitary gland. And in tertiary, there is a defect in hypothalamus. In primary Addison's disease, because the defect is in adrenal cortex, all three hormones released from the adrenal cortex are affected. But in secondary and tertiary, there is a defect in release of ACTH, or in tertiary, that is, there is a defect in release of corticotropin releasing hormone. Since ACTH controls only two hormones of adrenal cortex, there is a decreased release of only cortisone and dihydro. So because of decrease in ACTH or decrease in corticotropin releasing hormone, there is a decreased release of only cortisone and dihydroepiandrosterone sulfate. And aldosterone levels will be normal, and renin levels will also be normal. There is a decrease of ACTH, in turn there is a decrease of cortisone and dihydroepiandrosterone sulfate, but there is a normal level of aldosterone and renin. In hypothalamus, along with these findings, there is a decrease in release of corticotropin releasing hormone. In primary Addison's disease, there is a decrease in release of all three hormones. So there is no negative feedback to pituitary and hypothalamus. So in turn, there is an increased release of ACTH hormone from pituitary. ACTH is not synthesized as one hormone. In fact, it is synthesized as pro-opiomelanocortin hormone. It is broken down into three hormones. That is, pro-opio means enkephalins, melano means melanocyte stimulating hormone, corticotropin means ACTH. So it is synthesized as pro-opiomelanocortin. It will be broken down into enkephalins, melanocyte stimulating hormone, and ACTH. So if there is increase in ACTH, there is also increase in release of MSH hormone. So this will be the reason for hyperpigmentation of skin in primary Addison's disease. So this will be the classification of Addison's disease. So we'll study about the symptoms of Addison's disease now. In Addison's disease, there are totally three hormones which are decreased. First, we'll study the symptoms, the hormones wise. Because of decrease in cortisone levels in Addison's disease, there are a few set of symptoms that you should know. And I'm teaching you just in orientation to inicet and neetpg. You cannot study whole the topic of Addison's disease. It is not practical, and you should know the basics and very important things. So I'm going to be teaching you very basic things. So cortisone, because of there is a decrease in release of cortisone, there will be set of symptoms which include anorexia, that is loss of appetite, and asthenia. Asthenia means mental fatigue, and physical fatigue is simply called as fatigue, and weight loss, weakness, and weight loss. The most common presentation is fatigue and weakness. The other important symptoms which are because of decreasing cortisone include hypoglycemia, because it is cortisone is a counter-regulatory hormone which increases when there is hypoglycemia. So when there is a cortisone, decreased level of cortisones, there will be hypoglycemia. in non-diabetic patients. This is very important. So hypoglycemia in non-diabetic patients, first you should suspect Addison's disease. So two more important clinical symptoms because of decrease in cortisol include there will be hypotension. There will be hypotension. It will be unexplained hypotension in a patient. There will be unexplained hypotension. This will be because in normal person cortisol increases the vasoresponsiveness to vasopressin, that is ADH, and to angiotensin 2. So when there is a decrease in cortisol, levels, there will be decreased vasoresponsiveness. There will be decrease in vasoresponsiveness to mainly ADH, that is vasopressin, and angiotensin 2. So this will be the reason for hypotension in Addison's disease. This will be the one of the reason for hypotension in Addison's disease. And one more important symptom, one more important finding because of decrease in cortisol include euvolemic hyponatremia. Euvolemic hyponatremia. Why it is euvolemic hyponatremia and why it is hyponatremia? This is because of increased ADH production when there is a decrease in cortisol. In normal people, cortisol decreases ADH production. So when there is a decrease in cortisol, there will be increased production of cortisol. So this will explain the symptoms and findings because of decrease in cortisol in Addison's disease. Now the next set of symptoms, that is because of decrease in aldosterone include, because of decrease in aldosterone, there will be a set of symptoms which include, first we'll study about the physiology of aldosterone action, and then we'll find out what will be the clinical findings, clinical and laboratory findings after there is a decrease in aldosterone. So first, aldosterone acts on principal cells. This will be principal cells of cortical collecting duct. This will be luminal side, and there will be blood vessel side. And aldosterone acts on principal cells, and it will cause absorption of sodium along with water. In turn, it will excrete potassium into lumen, and this potassium that is excreted into lumen will be exchanged with H plus ions in intercalated cells, intercalated type A. So this is the physiology of aldosterone, how it acts. So when there is a deficiency of aldosterone causes decreased absorption of sodium, that will cause hyponatremia, and this decreased absorption of water and sodium, that will cause hypotension. So there will be hyponatremia, and there will be postural hypotension, and there will be, because of decreased excretion of potassium, there will be hyperkalemia, and this, because of decrease in potassium levels in the lumen of cortical collecting duct, there will be less exchange of potassium with H plus ions. This will cause accumulation of H plus ion intercalated cells and will be transferred back to blood vessels. So it will cause mild acidosis. So these will be the set of symptoms which occur because of decrease in aldosterone, and these are primarily seen in primary Addison's disease, because in central Addison's disease there will not be any abnormalities in aldosterone levels. Next we'll study about the symptoms because of decrease in dihydroepiandrosterone sulfate. The symptoms of decrease in dihydroepiandrosterone sulfate occurs mainly in females, because this is one of the major source of androgen in females. But in males, the source of androgen is, the main source of androgen is the gonads. So because of DHEA sulfate, because of decrease in DHEA sulfate levels, there will be loss of axillary and pubic hair, and there will also be dry and itchy skin, and there will be loss of libido. These are the main symptoms which occur because of decrease in DHA sulfate, that occur mainly in females. So this will constitute the clinical symptoms of Addison's disease. Then when do you suspect Addison's disease? There are two symptom complexes where you should suspect Addison's disease mainly. I'm telling you only important ones. When do you suspect Addison's disease? The first symptom complex is which include anorexia, asthenia, fatigue, weight loss, and weakness. This is the first symptom complex, and the second symptom complex include hypotension along with hypoglycemia. So when these two symptom complexes are present, first you should suspect Addison's disease and go for a screening test. So if you find any of these symptoms or signs, then you should go for screening test for Addison's disease. So the next thing is diagnostic part. First you should do screening test. In screening test we measure fasting cortisol levels or early morning cortisol levels. Early morning is 6 to 9 a.m. 6 to 9 a.m. usually. Why do we measure cortisol levels only during fasting or during early morning? Why do we measure them during early morning? Because usually we eat at 9 p.m. in the night. So if we have breakfast 8 a.m. in the morning, it will be at least 11 hours gap between two meals. So there will be in between there will be a window of hypoglycemia if there is no increase in counter-regulatory hormones. So cortisol is a counter-regulatory hormone that will increase and cause increase in blood glucose levels in that window. So the early morning is a time where the cortisol levels will be at peak. When they should be at peak, if cortisol levels are found to be low, then it is a definitive finding for diagnosis of Addison's disease. So the values of cortisol levels include, if the values come less than 3 micrograms per deciliter, then it is a diagnosis of Addison's disease. If it is more than 20 micrograms per deciliter, then you should rule out Addison's disease. If it is 3, and if it is between 3 and 20, then this is an indeterminate value. Then you should go for confirmatory test. What is confirmatory test in Addison's disease? The confirmatory test in Addison's disease is ACTH stimulation test. This test is also known as cosintropin or synactin. Cosintropin or synactin stimulation test. These two names, cosintropin and synactin, are the name for synthetic ACTH. You should give 250 micrograms of ACTH to a suspected case of Addison's disease. If you get the values above 20, then it's a diagnosis. Then it is a rule out. Then you should rule out Addison's disease, because there is a proper response to ACTH by adrenal cortex. But if it is value less than 14, even after giving ACTH, then it's a diagnostic of Addison's disease. If it is between 14 and 20, then it is a indeterminate value. Then you can consider one more test that is not usually done. That test is measurement of DHEA sulfate levels in serum. DHEA sulfate in serum. If there is a decrease in DHEA sulfate in a setting of clinical features suggesting Addison's disease, but there is indeterminate values of cortisone even after giving ACTH, then you can diagnose Addison's disease when there is associated decrease in DHEA sulfate levels. So this is how you diagnose Addison's disease. Once you diagnose Addison's disease, you should differentiate between primary Addison's disease and central Addison's disease. Central means pituitary and hypothalamic causes. How do you differentiate between primary and central Addison's disease? In primary Addison's disease, there will be decrease in aldosterone levels. In response to that, there will be increase in renin levels. But in central Addison's disease, there will be normal aldosterone and normal renin levels. One more way that you can differentiate between primary and central include measurement of ACTH levels. The ACTH level will be increased in primary and that will be decreased in central Addison's disease. So this is how you will diagnose Addison's disease, and you differentiate between primary and central Addison's disease. Once you diagnose it as primary or central Addison's disease, then you start look out for the causes of primary and central Addison's disease. What are the most common causes of primary and central Addison's disease? So first we'll study about primary Addison's disease. The most common cause of primary Addison's disease include autoimmune adrenalitis. Autoimmune adrenalitis mostly found as a part of polyglandular autoimmune disease type 1 more commonly than polyglandular autoimmune disease type 2, or it can occur alone, that is isolated autoimmune adrenalitis. To diagnose this autoimmune adrenalitis, you should measure antibodies against the enzymes which are involved in synthesis of cortisone. That is the one of the most important antibodies, anti-21 hydroxylase. Anti-21 hydroxylase antibody. So if you measure and you found this in serum of a patient, then you can diagnose the case as autoimmune adrenalitis as a cause of primary Addison's disease. And if as and when you diagnose this autoimmune adrenalitis, first you should rule out polyglandular autoimmune disease type 1 and type 2. And if they are there, your diagnosis is easy. And if they are not there, then it is a case of isolated autoimmune adrenalitis. For that, you should know what is polyglandular autoimmune disease type 1 and type 2. It's a syndrome. Both of these consist of three findings. To remember, there is a funny mnemonic called ACP Aditi. Aditi is a girl's name. ACP Aditi. So A means Addison's in both type 1 and type 2, of course. In type 1, ACP, C means chronic mucocutaneous candidiasis. In this type of candidiasis, it is a recurrent type of candidiasis, which almost always involves oral mucosa, and in skin it may involve face and scalp areas. P means parathyroid hormone. There will be decreased in parathyroid levels, that is hypoparathyroidism. And in type 2, ADT, Aditi. D means diabetes mellitus type 1, that is autoimmune diabetes mellitus. And T means thyroid autoimmune diseases. In thyroid autoimmune diseases, the most common one is Graves. And the least common one is Hashimoto's. So these two will be and mostly it will be the Graves. You can consider Graves as the only finding. That it is that most common in PGA type 2. So after ruling out these PGA type 2 and type 1, you can diagnose autoimmune adrenalitis as isolated autoimmune adrenalitis. And second important cause for primary Addison's disease is tuberculosis. For that, you should ask history of a patient, whether he has got a previous history of tuberculosis or if he is taking any anti-tubercular therapy, or you can diagnose a case using CBNAT. So this is how you evaluate if it is a case of primary Addison's disease. And if it is a case of central Addison's disease, the central Addison's disease is mostly because of pituitary cause. Hypothalamic causes are very rare, so we will discuss only about pituitary cause. In pituitary it can be a pan-hypopituitarism, or it is a isolated ACTH deficiency. It is very important. This you will study in pituitary topic, pan-hypopituitarism. This isolated ACTH deficiency is very important because the most common presentation of isolated ACTH deficiency is hypoglycemia, because this is not an acute condition, and because it is a central Addison's disease, there will not be any decrease in aldosterone levels. The only manifestation in here is because of cortisone. The cortisone will slowly decrease, which leads to presentation of hypoglycemia. So this is how you will evaluate for the case of the Addison's disease, whether it is primary or central. And in pituitary, pan-hypopituitarism, isolated ACTH deficiency. And in primary, how do you evaluate for autoimmune adrenalitis, and how do you evaluate for tuberculosis? And the treatment wise, it is very easy. You should just replace the mineralocorticoid and glucocorticoid. Replacement of both these hormones will constitute the treatment of Addison's disease. For glucocorticoid, will administer hydrocortisone. The dose should be more in the early morning and less during afternoon and the evenings to match the diurnal variation of cortisone in the blood. And for mineralocorticoid, will give fludrocortisone. So this will constitute the treatment, evaluation, and everything about Addison's that you should know. And one more thing that I forgot to tell you is, when there is a decrease in cortisone, in Addison's there will be loss of water, and it will cause hypovolemia because of aldosterone. So when there is a hypovolemia, body tries to conserve calcium levels, so it will cause hypercalcemia. Because of hypercalcemia, you can see auricular, that is auricular cartilage, and adrenal calcification. This adrenal calcification, you can see it in CT. So this will constitute the whole topic of Addison's disease. Thank you.